Hello, good evening to all of you. I welcome to all faculty members as well as the delegates, the respected delegates and faculty members for coming here and joining today's meeting with us. Today we are doing the 15th osmosis of this financial year 25-26 with the partner with the association with the Indian Palliative Association, and the most importantly, we tried a lot of times to having a meeting with the association with IPSC, and today finally we got the opportunity to bring up all our delegate faculties and respected faculties to all of you. So with that, I would also tell you that this is a webinar which is named as Osmosis. And the name of the webinar is Cancer Cachexia, Evolving Science and Practice. I am sure that will help the other audience, those are watching today's live meeting. They will be getting a insightful knowledge as well as practice knowledge, and as well as they'll be having a lot of important points from here. And way forward, I would also welcome Dr. Sanjay Kamble, who is our head medical affairs from Samarth Life Science. Over to you, sir.
Thank you, Saurabh, for that kind introduction, and very good evening to all of you, and also a very good warm welcome to all of the audiences who are watching us. So, before we begin the program, a small introduction from my side. So, we are Samartha, a organization that has been instrumental, operational since long time, with a humble beginning, and now that it has grown into a company which caters products to various specialties as well as to various other countries. And Conquest and Onquest divisions are these two divisions. So basically here we have the Onquest division which caters the oncology products, and the Osmosis program, which is a brainchild of the division, is really near to the heart of all the oncologists, because as Saurabh has rightly mentioned, this program has been widely appreciated. The reason being the experts who share their views on actual clinical practice, what happens is in the field, in actual practices with the patient. And that's the reason this is the fifth osmosis that we have, and it's really a great thing that we are having this meeting in association with the palliative care, Indian Association of Palliative Care, Delhi. So that's really very much we look forward for this cross-functional interaction on a very interesting topic for on today, that we have on management of cachexia, and how various multi-specialty people, how they encounter this particular clinical entity, and how do they really manage such patients. And I'm very much sure that their views, their expert insights, this discussion would definitely have a great impact on the audiences who are the rather the healthcare experts who are managing such conditions in their clinical practice. So with this short take on today, it's my privilege to welcome the program director, Dr. Megha Pruthi, ma'am. So Dr. Megha is the director, Pain and Palliative Medicine, Fortis Memorial Research Institute at Delhi, and she is the one who would be taking this program ahead from here. So welcome, Dr. Megha, and I request you to welcome all the experts and the faculties who have found time today to join with us for today's meeting, and introduce them and then take this ahead from here. Over to you, Dr. Megha.
Absolutely. Thank you very much. First of all, thank you, Samarth, for pushing us to do such things, because in clinical care, we kind of, get so busy that such things just take a sideline, but they've been pushing, and, so it finally is taking shape here. And I'm very happy to, have all the stalwarts in the field here with Dr. Dr. Gordas is there? Is he there?
Dr. Gwaldas is
He
not.
said he might, but
No.
yeah, he might not be able to join because he had some sudden commitment somewhere. But yeah, so Dr. Gordas agreed, and he's a very respected gastroenterologist. I'll call him. He might join us for the panel discussion. Then Dr. Anil Anand is there, a respected teacher to a lot of almost so many of radiation oncologists. We are happy to have Dr. Niranjan Nayak, esteemed surgical oncologist who's in FMRI. Then Dr. Swarupa Mitra, our dear colleague and senior in radiation oncologist. Dr. Mansi Sharma, who has been my senior from VMMC days. So yeah, Dr. Mansi is a medical oncologist at RGCI. Dr. Ashutosh Jain, who works with us, a dear colleague in medical oncology. Dr. Gaurav Channa, who is a director, pain and palliative medicine at Max Saket. Ms. Deepti, who helps us with all kinds of problems related to nutrition, our dietitian here, head nutritionist. Yeah. So, and of course, Dr. Neha, who agreed. So I thought, it'll be good to have a little putting cancer cachexia into context. So Dr. Neha, who agreed to present a little bit on cancer cachexia. Thank you very much, Neha. She's a consultant in radiation oncology with us here, the dear colleague. So yeah, I think let's go ahead with Neha's putting cancer cachexia into context. Are we good, Neha?
Yeah, we can start now.
All right.
Hello, I'm Dr. Neha, and I'm grateful to the organizers for bringing attention to cancer cachexia, a syndrome which is under-recognized that we encounter daily.
Ma'am, your screen is not visible.
Neha, will you share your slides?
Yeah, I'll share it.
Okay.
Yeah, it is visible now.
Yeah, could you please put it on the full screen? No. You have to click on the bottom side. Hello, ma'am. Am I
Slide.
audible? Yeah, slideshow
Slide.
mode.
Okay. Is it visible now?
Your slide is visible, but it is not on the slideshow mode or the full screen. No, in the right side bottom. Yes, you can see one tunnel-like logo. You should click on that, then it will come on slideshow mode. No.
Neha, you can put all the, sometimes it's not visible because of the faces that are visible, no? So the side ones, put them aside, like collapse all those that are visible on the side.
Or else we can share from our end also. That is also
Yeah.
comfortable.
I think Arvind has
I
the
have,
slide, so you can share first.
we have, yeah.
Okay, just give me one moment. I'm sharing the screen. Could you please? Oh, yeah.
Is
It
it
is
visible?
Yes, yes, it is visible.
Okay. So shall we start?
Yes, please.
Please, ma'am. Please, ma'am.
So today I'll discuss the evolving concepts in diagnosis, biology, and management of cancer cachexia. So why studying cancer cachexia is important? Because it still affects 50 to 80% of patients suffering from advanced cancer, and it appears to be the primary cause of mortality in 20 to 30% of cancer patients. Cachexia negatively impacts the quality of life and is associated with worse prognosis and shorter life expectancy because cachexic patients have poor tolerance to treatment and they face high treatment-related toxicity. Cachexia is defined by muscle loss and not weight loss alone. Nutrition alone cannot reverse it, so cachexia is not equivalent to starvation. Earlier, we looked for visible weight loss, but now we look at phenotype. We focus now on weight loss, and along with it, inflammation and metabolism. It is important because it allows earlier identification and enables prognostication and intervention. This has led to the structured staging formation. It is called UT staging system. UT staging system was developed by University of Texas and was proposed in ESCO annual meeting in 2025, which is based on 4 clinical parameters: BMI, serum albumin, neutrophil lymphocyte ratio, which is a marker for inflammation, and resting heart rate. And based on the scoring, the patients with cachexia are staged from stage 1 to stage 3. And it was seen that patients with stage 3 cancer cachexia had worse median overall survival when compared to stage 1, and it was statistically significant. Thus, this staging system helps in better prognostic stratification, and it helps us in identifying refractory cachexia. This is the table showing the scoring system for UT staging system, where the 4 variables and score is made according to their values. Now the diagnostic criteria for cancer cachexia is, in 2011, Ferron et al. Described cancer cachexia as more than 5% weight loss in 6 months, or BMI less than 20 with more than 2% weight loss, or sarcopenia with more than 2% weight loss. It is still considered as gold standard in research studies. The recent one is the GLIM criteria. GLIM is Global Leadership Initiative on Malnutrition. Its official consensus report and criteria were published in 2019, and they define cachexia using phenotypic as well as etiological factors, with inflammation being the key component in cachexia. ESMO clinical practice guidelines recommend GLIM for the real world practice because it is easy to apply and it integrates the disease biology. Now let's discuss about sarcopenia, or it is also called occult cachexia. Many patients look overweight but are muscle depleted. This is called sarcopenic obesity, and up to 40% are missed if we rely only on weight. So CT scan that we already do at the various codes like staging and cancer treatment assessment, the CT scan can be used to quantify muscle at L3. This is called opportunistic CT because the CT scan which already exists, which is routinely done during staging or treatment assessment, we can quantify the muscle at L3 level, and it is called L3 skeletal muscle index. We should start using these scans to quantify cachexia and identify patients in pre-cachexic stage and find a period where early intervention will lead to better survival outcomes. Now let's discuss about pathophysiology. Earlier studies showed molecules like pro-inflammatory cytokines, IL-6 or TNF-alpha, which are involved in complex process of cancer cachexia, while the recent ones have identified a key factor called GDF15, growth differentiation factor 15, and cachexia is now understood as brain-driven metabolic disease. GDF15 is secreted by tumor cells, which acts on GFRAL receptor in brainstem, which contains the appetite regulatory center, resulting in muscle growth inhibition and exerting anorexigenic effect. GDF15 does not just cause anorexia, but it also drives a sympathetic hypermetabolic state. This explains that force feeding like TPN or enteral feeding doesn't work in cancer cachexia. We need a target to block this pathway, GDF15 pathway, which is called ponsegromab, anti-GDF15 monoclonal antibody. And it is a recent focus now as it has been investigated in phase 1 trials and is currently entering a large phase 2 trial involving patients suffering from non-small cell lung cancer, pancreatic or colorectal cancer with cachexia and with elevated serum GDF15 levels. Now let's discuss about mitochondrial dysfunction. Mitochondrial changes also occur during cancer cachexia, which are still under study. Recent data suggests that even before muscle mass is lost, The mitochondria and skeletal muscle become dysfunctional, leading to decreased ATP production, resulting in fatigue. This explains early fatigue, which is seen before muscle wasting. Now, the guidelines to manage cancer cachexia. The earlier guidelines, which were published in 2020, they were conservative as there was insufficient evidence. But the 2023 rapid update changed the standard of care based on SWOG trials. Now, ESCO recommends pharmacological treatment for cachexia with low dose olanzapine, 2.5 to 5 milligram daily. Olanzapine is now considered as the first line for management of cachexia, as it shows consistent improvement in appetite and weight gain with better safety profile and easy accessibility. Corticosteroids are still recommended, but only for the short-term use due to associated toxicity with long-term use. Progestins are considered second line due to risk of thromboembolic events and lack of survival benefit. So, cachexia cannot be treated with a single drug. ESMO guidelines are more aggressive on multimodal approach. Nutrition, so it includes nutrition with exercise and pharmacological agents. ESMO strongly recommends against routine TPN or enteral feeding in end-stage disease where survival is expected only in weeks. It focuses on pleasure feeding and counseling. TPN or enteral feeding is suggested for fit patients who have longer expected survival. Now let's discuss about the emerging therapies. Ponsegromab, as I mentioned earlier, it is GDF15 monoclonal antibody. Phase 2 PROACT trial showed robust weight gain and functional activity improvement in patients with elevated serum GDF15 levels. This is the first drug since enamoxelin to show real promise. Enamoxelin is approved in Japan as it improves appetite but has very minimal benefit in muscle function. So to summarize, the diagnosis of cancer cachexia includes not only the weight loss, but includes skeletal muscle loss, inflammation, and metabolism. Cachexia is now stageable by using UT system of staging and is potentially treatable with olanzapine as the first-line pharmacotherapy, and GDF15 is the new biological target with ponsegromab-like targeted therapies, which may finally change the outcome. We are entering the era where cachexia may no longer seem to be inevitable. These are the relevant references. Thank you. Now I hand over to Dr. Megha Pruthi to proceed further.
Thank you, Neha. I think wonderful. She has actually made the work of analysts so easy. And so a lot of things that we are to discuss are already here. And thank you. So I think, yeah, without wasting much time, let's start. Okay. So you would like to share the screen for me, Khushi? Are you sharing my presentation? Is it?
You can do it. Dr. Megha, you can do it.
Yeah. Let me try and do it.
Okay.
Mm-hmm. It's getting paused. 1 second. Not there. Is my screen is visible, I think, yeah? So my screen sharing is getting paused again and again.
No, ma'am, it is not visible. Do you want me to share your screen
1 minute.
to share your slide?
No. 1 second.
Something is coming.
It's coming, but whenever I'm changing it, it's getting paused. Wait a second. Let me just put it there only. Let me put it from the starting. on the slideshow.
Yes,
Visible
now it is
now.
visible.
It is still visible. Yes, it's visible, right? And
Correct.
I'm pretty audible. I can hear myself. Very well. Very well. So I think Neha has made our work very easy, but we'll go ahead and discuss it, all this and get some clinical tips as well. So our session objective would be to recognize cachexia early, understand why nutrition alone fails, clarify the role of pharmacologic therapies, role of communication with patients and families, and focus on practice-changing insights. So first thing, Dr. Gaurav, although Neha has already answered it for us, but why is cachexia not simple starvation, and why nutrition alone fails? Dr. Gaurav.
So, like you said, cachexia is not equivalent to starvation. We are looking beyond what is loss of appetite. It is also systemic inflammation. It is also certain hormonal dysregulation, and also with the advanced cancer, uh, we see multiple systems getting involved. So that is why the solution cannot be a single pharmacological agent or just nutrition. And probably we'll have to see this problem with various lenses, and probably one of them would be nutrition, one of them would be pharmacotherapy, one of them would be communication, counseling, nutrition, and together that is what the ESMO recent evidence based recommendations are, that you need to focus on uh, all the things put into one basket.
Absolutely. Thank you. So cancer cachexia is not just starvation, because there is inflammation, it's a metabolic syndrome that's happening. So tumor-driven cytokines, they alter the metabolism. We understood the role of GDF15 here, and feeding alone cannot really reverse the muscle loss. That's very important for all the audience to understand. Well, let's do it case-based. So now we have a 64-year-old female with metastatic cancer breast, and BMI is 32. Weight is stable over last 3 months. She says, I feel heavy and weak. I can't climb stairs anymore. Her HbA1c is 6.8%, that's pre-diabetic, and CRP is slightly elevated. Now we move to Dr. Mansi. So, Dr. Mansi, now this is an obese patient, but she's complaining of weakness. So, when in your practice do you identify cachexia? Do you routinely screen for weight loss or sarcopenia? Would you order a CT composition analysis or DEXA? What is it that you do with such a patient when she comes to your OPD?
Okay, so first of all, if we just look at weakness, there are multiple, again, it's a multifactorial thing in cancer, right? So we have to identify what the reason for the weakness is. We look at other metabolic parameters also, like thyroid function tests, etc. I do refer all my patients who are on palliative therapies to our palliative care specialist a little earlier, as well as a dietitian earlier, so that any deficiencies can be caught and taken care of in time. One. Secondly, with regard to weight monitoring, yes. So each time the patient comes to the OPD, their weight is measured. We have an online system and the weight is recorded. So we always talk to the patients about whether they're feeling better, and whether it's associated with weight gain, weight loss, or whether the weight has remained stable. When do we identify cachexia? I think this patient seems to be more in the pre-cachexia range. So that's where I think my nutritionist would also help us a lot. With regard to a CD body comp analysis, as of now, we're not doing it, but that's great food for thought. I think I have some huge ideas to take back today. And DEXA scan, yes, we do that routinely when we feel that there is a bone loss. And exercise, I believe it's a very important part of the entire routine.
Absolutely, absolutely. Awesome. So we get some clinical clinical things. So, of course, early recognition is very important. History, including nutritional issues, as Dr. Mansi already said, it's very important to take the history that what are any risk factors that she's not able to, kind of ingest, like something called nutrition affecting syndromes, like simply pain can affect your nutrition, simply something like nausea, vomiting, all these things can affect your nutrition. So taking a detailed history to recognize this early would be important. Physical examination, focusing on loss of subcutaneous fat, muscle wasting, looking at the temporal region, deltoids, quadriceps, to look at visible loss of fat and muscle. Then objective measures like serial body weight, which, as Dr. Mansi said, most of the oncologists are already doing it. Lab measures like serum albumin. And as we said, yes, none of us is actually using CT for this, but yeah, it's a good food for thought that we can try and do it. And then Neha already mentioned about something called University of Texas staging system. This she already mentioned. So however, yeah, there's also something called nutritional risk index, which incorporates the albumin level and the weight or the usual weight of the patient. And we can also classify patients based on this. It's a validated tool, nutritional risk index, where patients can be classified as having no malnutrition, moderate, or severe malnutrition based on this calculation. It's a validated tool. Frankly, when I was reading, I got to know of this. I thought of sharing, it would be interesting. So yeah, okay. And yeah, we already talked about that, yes, about this. So DEXA, yes, routinely we use DEXA scan majorly for bone health, isn't it? However, they say that DEXA is sometimes also used for measuring rest of the muscle. However, it in a wet patient, like it also includes even anything other than bone is considered as muscle by DEXA scan, right? So if a patient is overtly even the water or edematous patients, that is also considered as muscle by the DEXA scan. So definitely CT L3 muscle index, which Neha mentioned, would be a better way to understand cachexia and sarcopenia in our patients. Okay. Yeah, of course, we mentioned this. Sir, so Dr. Mansi, we see many obese patients. Do you currently rely on BMI or body surface area for chemotherapy dosing? And does the risk of, in such sarcopenic obesity patients, risk of toxicity in these hidden cachexia patients, does it change your drug choice or dosage choice?
Dr. Megha, just for your information and update, Dr. Ashutosh has already joined from medical
Has
oncology.
I could not
Yeah,
see.
yeah, he's there. He's there. He's there.
Oh, he's there now. Oh, Dr. Ashutosh, are you there?
Yes, madam. Yes,
Would you
I am
like
there.
to take this question, please? I could not see him. That's why I am.
So
Thanks for
many a
letting me
times,
know.
madam, we don't do any specific test for obese sarcopenic patients, but many a times we see muscle wasting as a part of physical examination that you already told. So as a result of which, probably they have already developed poor performance status, or screening, some physical screening tests like rise up or get up and go and hand grape and all those things. So these things are evident by physical examination, and many times we just rely on the physical examination because these are metastatic patients for which we are talking about, and many times we are following them closely for a period of time. So most of the time we know that they are developing sarcopenia and all those things.
So does your we were just saying about sarcopenic obesity. So about that, do you use body surface area for your chemotherapeutic dosing?
So we tend to use many times body surface area only, but we calculate adjusted body weight for, especially for some of the drugs which are lipophilic, to avoid excessive chemotoxicities.
All right. So it is drug specific, yeah?
Many times, yes.
Yes. Thank you.
And patients, and we try to use this thing, adjusted body weights for that.
Oh, very well. Thank you for good clinical tips and things like, hand grip and visible sarcopenia as you are watching them serially over the years. Thanks. That was important. So to Deepti, so So here we are talking about sarcopenic obesity, right? So Deepti, we talk about 1.2 to 1.5 gram protein per kg for her BMI, so BMI 32 that was in our patient. What would be a massive amount of that would be quite an amount of protein, isn't it, if calculated on actual body weight? So do you calculate her protein needs based on her current weight or her ideal weight?
So, first of all, thank you for getting me on this platform. So, in such kind of patients where patients are morbidly obese and the BMI is above 30, as per the recommendations, it is not the ideal body weight, but it is the adjusted body weight that we calculate, and based on the adjusted body weight, because it takes into consideration the ideal body weight plus addition to that 1/4 of the ideal body weight. So you adjust that weight for the patient, and then you go up to 1.2 grams per kg body weight, adjusted body weight, to meet up these protein requirements. So normally the recommendations are zero 0.8 to 1 as per the recent RDA guidelines, but in these conditions, we go up to 1.2 as per the minimum requirement.
Very well, that's helpful. So adjusted body weight, not ideal, not current, but adjusted body weight.
Yes.
And to build up the muscle, we usually push, high calorie, carb rich supplements for such cachexic patients. But she's pre-diabetic. So how would you design a diet that drives like protein synthesis as well without spiking her insulin and driving more fat storage? And what specific supplements do you recommend for such diabetic cachectic patients?
So, Dr. Megha, first of all, we need to get out of this concept, all of us talking about just the high protein. So, because I have seen in my practice, most of the time we are just land up, guiding the patients on the high protein, but we forget that minimum amount of the energy coming from the carbohydrates and fats is equally important to give that protein sparing action. So I would say in such diabetic cachexic patients, ideally we should calculate to 30 to 35 kilocalorie per kg ideal body weight, or at least 25 to 30 kilocalorie if it is an adjusted body weight for the patient, depending on the stage of the cachexia the patient is in, taking out the medical history. So this would be our target. However, we can reach the target over a period of time gradually to prevent refeeding syndrome by assessing how much the intake for last 1 week exactly the patient was having, taking up a dietary history, considering the refeeding biochemical markers of hypophosphatemia, hypomagnesemia, and hypokalemia into consideration. And then at least target protein would be again 1.2 to 1.5. 1.5 definitely needs to be there. And in such patients, the most important thing is that we should divide all the meals, the major and the minor meals, the snackings that we try to give for these patients, 2 to 3 hourly meal pattern, calorie as well as protein rich. So it is not just the protein. So we have to actually take the history and then come to a conclusion what is a deficit. If, say, for example, the patients are able to have adequate carbs coming from the diet, but it is a protein which is lacking, then we go for the supplements which are rich in the proteins and less in the carbs. But if the intake in general is low, then we should supplement with the supplement which should have all the three, the carbs, the fats, and the proteins. And MCT based fats can be, since they do not need any absorption, I think they are better absorbed for patients and to build up their calorie intake in case of nausea, vomiting. And I have seen a very positive results with my patients while we go for the MCT based fat, adding them into their diet.
Yeah. So you mean middle chain MCT is
Medium chain
medium chain
triglycerides. Yeah.
triglycerides. Yeah.
Yeah.
Thanks, Deepti, for that input. So next we have Mr. Verma, who is a 55-year-old male, stage 3 oropharyngeal squamous cell carcinoma, HPV positive. He's on curative concurrent chemoradiation, high dose cisplatin plus radiation ongoing. He has already lost 6 kg, like 8% of his body weight due to due to pain and odynophagia before starting the treatment only. Now, palliative medicine team says that he should have a peg tube. He refuses and he says that I can still drink shakes and I don't want a hole in my stomach yet. Okay. Now, to Dr. Anil Anand sir. So, do you still push in for PEG now to guarantee nutrition, or do you agree with the reactive approach that Mr. Verma has, that, you know, to keep him swallowing as long as possible? And is swallowing muscle preservation now a priority over calorie counting for you, sir? Anil Anand sir, is there?
He seems to be have disconnected or something because he was adjusting something.
Yeah, I can't see him. It's okay. Dr. Swarupa, ma'am, would you like to take this?
Yeah, first, let me congratulate Samarth and Megha for bringing up this topic. This is so less talked about, and yet it's so, so important. So when you're talking of PEG tube, you know, the situation you have raised, we would not allow this situation to come. So when a patient of head and neck cancer, like here, the oropharyngeal carcinoma, when we start the treatment, we have to be very, very careful. The first thing which you had mentioned, the counseling of the patient and the family, is very, very important. They have to be reminded that he will have swallowing difficulties, and so that he's not very scared. And these are all part of the treatment. So this counseling needs to be done to the patient and the family. Second, we start off, I would always, really emphasize with starting off with the swallowing therapy. That does a huge, huge amount of benefit to the patient. We have speech therapists and swallowing therapists with whom, at the initiation of the treatment, a visit should be made. And they teach, and with the swallowing therapy, we have seen the patients, many patients have a longer period without enteral feeding. Third is that when the patient is on the treatment, I personally, I have seen many radiation oncologists, we keep a tag of how much the patient is eating. Every patient is given a diet chart. And that diet chart every day, hourly, how much the patient is taking, and at the end of the day, the total amount of the volume of the whatever he has eaten, and what he has eaten, that he and the weight. So this is maintained throughout the treatment on a daily basis. And with my experience of so many years, I can say the counseling of the patient, a swallowing therapy, or before the start of the treatment, and the diet chart maintenance, these play a huge role in maintaining weight throughout the treatment. And in radiation, we have another responsibility to see that we do not give any breaks in the treatment. That is very important for radiation treatment, the minimum break we want to give during the treatment. So that is why all the more this much of counseling the patient and teaching him how to swallow is important, and it helps a lot.
Absolutely. Okay. So in such a patient, now, if you have such a patient, will you, so this is the patient who is already lost, would you recommend a PEG tube butt? Or
so again, only weight is not the criteria to decide whether to give him a PEG tube or not. PEG tube, of course, not. I think I would first see that how much time, is it a short time period he will need help in the feeding? If it is a short time, which is mostly for radiation patients for head and neck, I would not go for a PEG tube because it is an intervention. It has got other complications. I would rather go for a Ryle's tube or the nasogastric tube. But again, that too will not be the first approach. I would rather get him admitted or give him some fluid and put him under the dietitian to see his weight. And yes, if we see that there is odynophagia and he cannot really eat in spite of trying, then of course I would put in a nasogastric tube and of course monitor it. We do not want to put the patient on the nasogastric tube right in the beginning, and nor do we want it to be done all throughout the treatment. Something very important which I missed saying is that aspiration. For such patients, micro aspiration and aspiration is a huge problem. We do not want any patient to get into an aspiration and land up in the ICU with other complications. So I would rather, for this patient, I would rather counsel him and maybe put in a nasogastric tube.
Okay, thanks. Dr. Gaurav raised his hand. Do you want to say something, sir?
And I was just mentioning what Dr. Sarupa emphasized later on, that yes, we have to take care of his nutrition, intensive observation, and maintaining a chart, I think, would be more necessary. Or dinophagia would definitely in oral cancer patient would require good analgesia,
Pain
uh,
management.
pain
Yes.
management for the swallowing, and also for ongoing radiations that patient will start. But I agree that PEG would be too invasive to start on, but then also what I wanted to ask Dr. Sarupa was,
Yeah.
how much of swallowing muscle preservation are we challenging by putting in a tube, and whether that is a consideration while considering either PEG or tube?
Preserving the swallowing muscle, we do it right in the beginning of the treatment when we plan the patient for radiation. So when we do the contouring with all these muscles which help in swallowing and which we do not want in the aspiration, the DARS muscles, we conserve them. They are placed as an organ at risk. So radiation dose constraints are kept so that they are minimized, minimal exposure to these muscles are there. So we start that right in the beginning. And during the treatment, if the patient needs a Ryle's tube, then also during the treatment, also the swallowing exercises are kept on, the patients are kept on swallowing exercises. And I've seen the swallowing exercises, we have seen in our practice with proper swallowing exercises, the Ryle's tube insertion rates have diminished. They're much lower than before.
Agreed. Agreed.
Very well. Very
So
well. Yeah.
the idea was also to focus that not because of radiation, because of disuse when you put a PEG
Yeah,
or
yes. Yeah, that is that is why that we do. That is why I said I don't want to put on a Ryle's tube for a long term.
Yeah.
Not
So
at all. And putting a PEG tube again, this puts the muscles of swallowing and the base of the tongue, they are disuse atrophied, has been seen. So that is why another reason the PEG tube is not placed.
Thank you, ma'am.
Absolutely. Thank you, madam, for bringing, because many times we do not, consider this point. So it's important that if we give prophylactic PEG or NG tubes, to continue with swallowing exercises so that patients, because it has been seen that, long-term swallowing outcomes may be poor in patients who are put prophylactically on PEG or NG tubes.
And initially, we used to see they had become dependent on the Ryle's tube.
Yeah, that's what
2 to 3 months they were on Ryle's tube.
Yes, because of the muscles, they atrophy.
Yes, exactly.
From lack of use. Very well. So Dr. Gordas could not join, but yeah, that's fine. So I'm not sure if Dr. Anand is still there, but though, ma'am, so if a patient loses more than 10% of weight during radiation, the mask often doesn't fit anymore, requiring replanning. Do you have a specific red line for weight loss that triggers automatically, like stop and refeed the patient before you go, or do you push through to avoid a biological cost of the treatment gap? So considering if a patient has weight loss,
So so these are two separate things.
Yes.
So one is the weight loss and replanning. So we see like I said, every patient, he's weighed every day. So not necessarily if there is a weight loss that a replanning will be needed. We do a replanning when there is a weight loss. Of course, the mask becomes loose because planning volumes are outside the body or they are missed. Then a replanning is done, and this is called an adaptive replanning. and whether there is no red line for weight loss when we should stop and stop. So the why we do a replanning, I told you, when the volume to be treated is outside, we are missing. And no, and I am any radiation oncologist would be the stopping the treatment would be the last on the card. We don't want to stop or any gap in the treatment. So for such cases, I would rather again counsel the patient, if required, get him admitted so that we can monitor him closely and give him supportive medicines to reduce the pain, if required a Ryle's tube, but stopping the radiation would be the last of my choice.
Yes, very well. So yeah, you already mentioned about swallowing therapist and the practical tips. Thank you. So next we have case 3, who is a 58-year-old male with pancreatic cancer. Weight loss, he's lost 9% of his weight in last 4 months, BMI 19. He's anorexic, 7 on 10. Early satiety is he has nausea. His albumin is 3.2 and neutrophil lymphocyte ratio is 5. That shows high inflammation. Now he is planned for surgery. He is a surgical candidate. To Dr. Niranjan sir, is the evidence strong enough for you to willingly delay a major surgery for 2 weeks or so to medically optimize this, or is the fear of tumor progression still too high if this patient is surgically operable?
Yeah, good evening. Yeah, thanks for inviting me into this seminar. Definitely, what we call in these patients, the plan starts right from the beginning. It is called prehabilitation. So we have to prehabilitate the patient right from the beginning as soon as the surgery is planned. So whenever patient has significant cachexia, then optimization is very important. Delaying surgery for 2 to 4 weeks sometimes may not be a big problem. And but most of the time surgical patients, they are in pre-cachexia phase rather than proper cachexia phase. So like overall prehabilitation will improve the overall outcome. Most of the time we take help of our dietitian, and wherever we cannot wait, then better to send the patient for neoadjuvant therapy so that disease does not progress. So we have to optimize the risk of delaying surgery, whether the tumor progression is very high or there is delaying the surgery, will it improve reduce the risk resectability. So these things we have to assess. And then again, if a patient is very positive, then ready to do undergo proper rehabilitation with all the like exercise, then chest physiotherapy, proper nutritional supplements and all. Then we can wait for 2 weeks and then go ahead with surgery.
Awesome. So yeah. So sarcopenia is not really a contraindication. You would weigh the risks versus benefits, is it?
Exactly, yeah. It's not an absolute contraindication, but definitely delaying the surgery like 1 to 2 weeks is definitely most important thing. And here multidisciplinary approach like surgeons and anesthesiologists also we take into consideration their assessment, pre-anesthesia checkup, then nutritional support from the dietitian team, and definitely the assessment of sarcopenia with CT scan. Definitely we are not doing it routinely, but definitely we can consider, as Dr. Mansi also told. So it's definitely a good thing. Probably we should start implementing that. And maybe like most of these patients, they undergo whole body PET CT scan before undergoing any surgery. So if our CT like radiology or nuclear medicine colleagues can give us proper assessment of muscle mass and sarcopenia, then maybe it will help in weighing the risk and benefits of further proceeding with the surgery.
Absolutely. So I would just like to add in all these patients, the nutrition affecting symptoms must be addressed, like nausea, vomiting, constipation, diarrhea, any pain. So all these symptoms are again very important, because many times nutrition is affected because of these other symptoms than the nutrition, I mean, anorexia itself. Right. So it's
Yeah.
very important to take care of all these symptoms in all such patients. Thanks.
Yes.
So let's have a little talk around megestrol progestins versus olanzapine. So first, let me have a word with Dr. Ashutosh. Dr. Ashutosh, what is your take on what in practical purposes? I mean, Neha did mention about the guidelines and stuff. So practically, what exactly are you using these days, megestrol, and when would you start it?
So, Megestrol has been, madam, well known or age-old treatment for this, because this was the only treatment which was approved for cachexia. And as soon as we see sarcopenia or pre-cachectic state, we tend to start Megestrol, because as you have already seen in the previous cases, especially with regards to GI tumors and all, where anorexia and all is a major factor, then in those cases, probably Megestrol is one of the first choice of treatment. And apart from these, as we have seen in head neck case, there can be other factors which are contributing, including odynophagia and all those things. And yes, olanzapine also we have seen 2.5 to 5 mg lower doses. They are also beneficial. As 2 years back, there was ASCO update also, which showed there was betterment in clinical endpoints with help of olanzapine. So both the agents, but we tend to start Megestrol first. And many of our patients, they are already receiving olanzapine as a part of CINV prophylaxis with each cycle for 3 to 5 days almost.
Yes, that's right. That's right. So, Dr. Gaurav, what is your practice for such? When would you start megestrol in pre-cachexia state? And I mean, when exactly do you, in your practice, do you start megestrol
So yes, I mean
versus olanzapine as well?
to start something like Megestrol, you would need a diagnosis of cachexia. We would like to probably force on other modalities to manage weight loss when it is pre-cachexic stage. I think it would be too early to introduce megestrol. So every drug comes at a cost. So the risk of DVTs and embolism, thromboembolism is what the cost of megestrol is. So in a patient who is able to walk and has no prior history of any thromboembolic event or no cardiovascular neurological history is not there, and is able to carry out all his daily activities, PS1 2 patient. Yes, we can definitely consider megestrol when there is a diagnosis of uh, these cachexia is there. And like our first case where the patient was metastatic breast cancer, and there is a history of hormonal positive cancer, hormonal responsive cancer. Yes, megesterol can be considered as a adjuvant to hormonal therapy, but the dosages would vary, I think, and that helps with more than the weight gain. It would help with the other symptoms which are there with the hormonal agents. Olanzapine, like, yes, Ashutosh sir also mentioned that it is also used as a part of CINV protocol. So the debate would continue with the endpoints what we are taking. Like, yes, in a patient who has a history of anxiety, nausea, I would prefer to use olanzapine, and where I can't use megestrol with a history suggestive of thromboembolic events, we would prefer to use low dose olanzapine. So you will have to probably select your patient wisely when the pharmacotherapy is being considered.
Very well. Dr. Mansi, your take on this? Practical and for Magestrol, what exactly, what practical tips do you tell your patients? And how do you select patients for Magestrol versus olanzapine in your practice?
Okay, so I think both Dr. Ashutosh and Dr. Channa had covered them quite well. To put it into perspective, we look at the patient first, we look at the comorbidities, we look at the cause. So, uh, if the patient has a lot of gastroparesis, then we try to say include something like a metoclopramide based regimen. If the patient has low appetite, then we would prefer to give olanzapine. Thirdly, for Magestrol, I do give it in low doses. We do give olanzapine also, but we have to be very careful because because Magestrol does cause thromboembolic events. So if there's a patient who has a history of DVT, as he rightfully said, or a cardiac comorbidity where we do not want fluid retention, or uncontrolled diabetes mellitus because Magestrol can further worsen the hyperglycemia, then we prefer not to give it. With regard to olanzapine, I think the residents here in this forum as well. The most important thing is that you need to check for drug interactions. Olanzapine has a lot of drug interactions, so you need to make sure. And more importantly, olanzapine is sedative. So a lot of the times our patients are on multiple painkillers. They're taking gabapentin, they're taking morphine, and they're already pretty heavily sedated. So that is one place where I would probably not want to give olanzapine, or if I do give, start at very low doses, counsel the patient's relatives about looking for sedation. I do mention that in my prescriptions, and then take it from there. There was one study which looked at some synergy between Magestrol and olanzapine. So if there's a very fit patient, like those lean, thin patients where they're losing weight but otherwise relatively fit, I might just consider a combination of the two. What else? The coming back to the head and neck patient, he was getting high dose cisplatin. So that's where, as we mentioned before, olanzapine would have been great for that patient. It would take care of the nausea as well as take care of partly the cachexia, along with a good prokinetic. That's it. Drug interactions, probably the most important thing. That's the only extra point I would like to add.
Yeah, absolutely. I think we covered most of it. So a little bit I'll add on. Dr. Swarupa, would you like to take a word on the dose of Magestrol acetate?
Magestrol, although we can go up to about 800 mg, but I have not given. I prefer going on a lower dose. But of course, the patients who come to us for radiation treatment, they are not so cachexic that I need to increase the dose of Magestrol. So generally, when I have given 160 milligram twice daily, maximum thrice daily, I have given, not more than that.
Yeah. So doses, the recommended doses for Magestrol are majorly for appetite stimulant, as an appetite stimulant are anywhere between 160 to 400 milligram. Can go up to 800, but then so 160 to 400 is the recommended dose as appetite stimulant, and it should be taken with food. It's better absorbed like that. And yeah, I think we did discuss all this, who benefits and who should not receive it, dose duration. And okay, just a little word about who would like to take, how long would you give Magestrol acetate before you actually say it is working or not working? Anybody who would like to take that? Somebody should.
Okay, so well, it depends again. So if you're giving it to patients who are on chemoradiation where there's a finite duration, and then the appetite's going to get better, the nutrition is going to get better, it's a finite duration. For those patients where it's a palliative intent, we know they're going down. I think when we see patients before each chemo cycle, when we go through all the drugs that they're getting, that's when we think and ask both the patient as well as ourselves whether we've reached the goals that we've set for them. So has the cachexia been, is it improving? Has the patient come back to baseline levels? Is he improving after taking migestrol? If not, then probably give him some more time or her some more time. And if still not improving, then stop and maybe think of an alternative treatment at that
So
time.
how much will be that some more time? That's what I think.
So I'm not sure what the guidelines say. I don't think the guidelines say anything actually. I would say give them at least 3 weeks or to 4 weeks before we take a call, because it'll take time for the appetite to come back, for the weight to be gained. And again, like I mentioned before, we love our nutritionists. They're amazing. And we do take their help a lot, and our palliative care specialist as well when it comes to this.
Thanks. Yeah. So I think that is true. So 3 to 4 weeks, we must give anywhere between 2 to 4 weeks. Actually, that trial must be given before we say it is working or not working. And frankly, either of migestrol versus olanzapine, none of them have effect on overall survival. But yes, they do improve, appetite. They might improve a little bit on the weight as well. So yeah, they work. So yes, there is no, and majorly there is for migestrol, there's no actually muscle weight gain. It's majorly the fat that's gained, and it's good for short-term palliation. We discussed this, yeah, adrenal suppression, VTE, and edema. We covered all this. Okay, so I think steroids. Dr. Gaurav should take it because we use steroids a lot. I'm sure everybody does. So Dr. Gaurav, when do you use steroids as an appetite stimulant or in cachexia patients? What would be the role of corticosteroids here?
So I think corticosteroids are probably not mostly used for cachexia because of the fear of muscle dystrophy. But if they are to be used for a very short duration and in a dose of 4 milligram dexamethasone, can be used if there is something which the patient is looking forward to for maybe a week or two, so that the chances of muscle dystrophy is less and hormonal dysregulation, metabolic derangements are kept to the minimum, and the infection risk is also kept to the minimum. And anybody else can also.
Anybody who would like to add on to this? Dr. Swarupa, ma'am, Dr. Ashutosh, Dr. Mansi, anybody who would like to add what is their practice on using steroids for appetite stimulation? So we usually, yes, Dr. Mansi wants to say something. Go ahead.
Not really. I don't really use it for appetite stimulation. I agree with Dr. Gaurav, only if needed for very short cases, but honestly, I don't. I mean,
yes. So only for very short duration that steroids can be used, and they give a feeling of well-being for in our palliative medicine patients. Sometimes we use them for multiple purposes because, they also help in pain. They might help in a little more feeling of betterness. So yeah, they might serve multiple purposes. There's a lot of things going around cannabinoids. Everybody is prescribing CBD oil for a lot of things. Dr. Ashutosh, would you like to do you use CBD oil cannabinoids in your practice? They say the MRs that come, they say that they improve appetite and feeling of well-being. What do you say?
So yeah, I have not used it, but I've seen few patients taking that, and some of them probably saying that probably there was some improvement, especially with regards to pain and something appetite. But there is data, and probably ASCO is against using these drugs because probably there was no benefit. So we are not using it.
Yes, absolutely. So there is no data that ASCO does not recommend cannabinoids for cancer cachexia. And anybody who would like to take something last 5 minutes, anamorelin, the ghrelin agonists and those things, although it's not really available in India. So There are emerging therapies, agents like anti-GDF-15, which Neha mentioned. It's quite a promising agent, I feel, and since it's working on the cause of it, and might help, I think. So steroids we discussed for days to weeks only. Long-term use would only worsen muscle wasting, and consider it only in advanced disease or end-of-life care. Anomorelin, it's a ghrelin receptor agonist. It improves appetite and lean body mass. There is no proven survival or functional benefit. There is more muscle sparing than magestrol. Cannabinoids have, again, limited weight benefit. They're not recommended. Okay, so we have with us Deepthi. Deepthi, what do you say on omega-3 fatty acids and all these nutraceuticals? Would you like to have a comment on that?
Normally, during cachexia, what we need to take care of the new micronutrients are vitamin D, B12, definitely iron, and these are the main three micronutrients. Rest of the micronutrients we can go as per the normal recommendations, as per the recommended dietary allowances. So idea is that we try to give them again, lot of fortification of the foods along with these nutraceuticals, which are having the wholesome with all the micronutrients in them, rather than just going any protein supplement which will not have the micronutrients, because obviously their appetite is already on a lower side. They are not able to have adequate amount of not just calories but micronutrient deficiencies is something which is very commonly seen. And as we have talked about, cachexia is all about inflammation and disease effectiveness. So chances of infections are very, very high, which can be prevented with these micronutrient deficiencies. And that's where the guidelines came to regarding the ESPN guidelines, where we started the tube feedings also primarily with the formula-based supplementations. And while at discharge also, we recommend the patients not completely move to, in case of their oral intake, not completely just dependent on to the micronutrients from the food or from the kitchen feeds, but also supplement them with the nutritional supplements, so that even the drug interactions, food drug interactions can be taken care of.
Very well, thank you. So as an oncologist, Dr. Mansi or Dr. Ashutosh can take it. If a drug improves weight but doesn't improve survival or tumor response, is it worth the financial toxicity to the patient?
Anybody else? Or should I answer?
Both of you. Yeah, both of you would answer that.
Okay, let me start first. Oh, if it's very expensive, maybe not, but I would still have the discussion with the patient and the family members. So after a certain point of time, the quality of life is equally important, and maybe take a joint decision when it comes to it, right? So it depends. I would say it depends. Right now, it's not available. When it does, let's look at the cost and then take a call.
Yes. What will your take be, Dr. Ashutosh? As an oncologist, do you think it's worth the financial toxicity to the patient?
So same way, ma'am, as ma'am said. So if it is financially toxic, probably I will not add. But if it's feasible for the patient financially, so at least if it is improving quality of life, then we would consider adding.
Because many times, even if we discuss and tell that, you won't be able to, I mean, they understand and they feel that they are not taking it just because they cannot afford it. Or so that also adds kind of a guilt and a thought to the family. So yeah, introducing any medication must be carefully thought about by the oncologist as well, isn't it?
Yeah, Dr. Sumegha?
Yes, madam, please
Yeah, I
take it.
just wanted to, I think that's a very good thing you said, very, very important and a very empathetic thing. That many times, we're counseling the patient, we forget that, one of our words can bring guilt in the patient, that I could not do this for my father or mother. So when we counsel, we need to stress that this is probably not very important. It is not imperative. But if you can do. But if you can, I always add this when I say such things, I always add this, that if you cannot, don't feel guilty. I always add this to all my counseling. So I think this is a beautiful thing which you have said.
Yes, it's very important for us, to understand this. Thank you. Yeah, so I think just a comparison of megestrol acetate with olanzapine to summarize it. It's a progestin, while this, is a 5-HT2C and dopamine antagonist. And thromboembolism risks are, although we did discuss, I don't think we need to. I already said that. Yeah, we're running late anyways. So yeah, I think we already discussed this. Just one last case about 72-year-old male with squamous cell carcinoma lung, ECOG4, bed-bound, survival prognosis is less than 2 months. Now, patient is barely eating. Wife is distressed and requesting for TPN or any strong appetite boosters. I'm sure we all deal with this, right? So, what would, oops, okay. This was supposed to be a little ahead in this, but medical oncologists can take this. At what point does cachexia make a patient unfit for immunotherapy or chemotherapy? Do you have a specific cutoff like albumin less than 2.5 or PS3 to say no more systemic therapy? This patient was ECOG4 anyway, so not regarding to the patient that I just said, but at what point does cachexia make a patient unfit for chemo or immuno?
If the patient has established cachexia with, where we're not really expecting any more reversibility in terms of the disease, we look at the life expectancy of the patient there. And of course, with any patient who has a ECOG PS of 3 or of definitely 4, we would not be offering systemic treatment there. We would be offering best supportive care.
Yes, yes.
However, if a patient has come with an ECOG PS3 because of very poor nutrition, say because of esophageal cancer or head and neck cancer, where if we put in a tube and the patient is just at the beginning of his disease, then we try to build up the patient as we discussed before, right? Right, like that Whipple's patient. So I would say if we look at the patient, we look at the disease, we look at the survival expectancy and what are we expecting. And I think that's it, yeah. For that PS4 patient, I would not really request, have that session with the wife about what Dr. Swarupa just said, about explaining to them that this will not help. In fact, it causes more distress to the patient because they're not really hungry at this point of time. My tip, if sugar is not an indication or contraindicated or no major issues, I usually offer them vanilla ice cream and they'll love it. So, just to boost their mood a little.
Yes, yes, absolutely. Okay. So, yeah, so now, Dr. Gaurav, is in such a patient, would megestrol be strictly contraindicated? The wife asks for strong appetite booster. Would you consider steroids here instead? How do you justify the myopathy with that? How do you justify this? And what would be the role of de-prescribing appetite stimulants at this stage? Dr. Gaurav.
So I think first we need to analyze what is the problem. I mean, it is with regards to the patient or it is more with the family not accepting the condition of the patient.
Yes.
So we need to find solution to both of them, and probably it is difficult to find a solution to first problem. So we should focus more on the second, like Dr. Mansi also said that we like to have a discussion and a communication with the patient's family to make them understand that what his body is undergoing is progressive in nature and probably not respond to any more medications or to artificial nutrition. Everything will come at a cost, and the cost probably can be infection or can be infection or muscle atrophy, myopathies, and also there can be also when we are using TPN, also we are risking overtly hydration, we are risking refeeding syndromes. We are also probably saying that the issue is not help. Probably we are trying to reverse what is naturally happening, and what we see in our end of life care patients, where the expected life expectancy is in weeks or days. By initiating artificial nutrition, we are reversing the ketoacidosis, which is will happen as the disease progresses and patient is not able to eat, which has its own benefit sometimes, that the patient is euphoric and perceiving the pain less. So these things probably would give us more, the counseling with the patients and the family will give us more guide us to move ahead. And I think it would be the right time for deprescribing all appetite stimulating agents at this point of time.
That's right. I think Sir is not there, but at what point do invasive? Yeah, okay, we all understand that GI evaluations would only add burden in especially in ECOG 4 patients. However, they might be required when the patient is on disease-directed therapy and has refractory vomiting or anything, then invasive GI evaluations might have a role. Yeah. So, so it's not there, but many times this happens, no, that the family insists on a PEG tube or an NG tube. So, yeah. So, Deepti, in this refractory stage, do you formally stop calculating calories? Like clinically, yes, we all do, but as a dietitian, do you formally stop calculating calories? How do you teach the wife that tumor is hijacking the nutrients, and force feeding will actually feed the tumor metabolism and might cause even aspiration? So what is your take on this, Deepti?
So, see, if the intake is almost negligible, it is not that we are stopping them to have from anything. And definitely, whatever they are able, comfortably, they are able to have. So, I think calculating calories doesn't make sense at that period of time. But definitely, depending on family, we need to make them understand and have to get them realized with the situation. So hijacking nutrients, definitely we keep them, counseling them, whatever small amounts they are having, how to make it more nutrition dense, whichever way, by adding the supplementations, or generally how to make, by various methods which they feel that they can have it and they might enjoy it during this stage. But I think calculating exact calculations very difficult to provide with that.
Yes. Very right. So we already, although discussed this, I kept it towards the end, that framing expectations at this point is very, very important, isn't it? That we all have to be there, and we need to counsel it on call. And of course, medical, surgical, and radiation oncologists are their first primary physicians. So telling them and making the family understand that appetite improvement is not really reversible of cachexia. Symptom palliation would be more important at this point, and avoiding unrealistic expectations. This would take a lot of compassionate counseling, and multiple times explaining them about this would be very important. Niranjan sir, so, how often do you, in your as a surgical oncologist, deal with such patients? Because many times when you are the first people who a patient is with, so they come back to you even when the patient is very sick, isn't it? So how do you feel is the importance of framing their expectations by the primary physician as you?
Yeah, most of the time, palliative situation, patient goes to medical oncologist rather than surgeon. So, but anyway, yeah, definitely it's very important. You have to discuss with the patient's relatives very empathetically. You have to prognosticate and give exact picture what is going to be like what will be the outcome and what is going to happen. And like most of the time, other than these fancy medicines, just giving good nutrients and multivitamins and nutritional support, as Dr. Deepthi told. So that will make significant difference in these patients' life. So prescribing proper multivitamins and protein powder or like nutrients, that is, and whether it is even like home-based nutrition is also going to help these patients. And then whenever there is a significant problem, then we should refer to palliative care specialist.
Thank you, sir.
Thank you.
Yeah. Absolutely. This compassionate counseling in cancer cachexia cannot be replaced by any appetite stimulant, anything. This is definitely the most important thing that all the oncologists, palliative medicine physicians have to understand. So, yes. We must avoid framing this as failure of care, that we are not able to give disease-directed therapy because the patient is too frail. So this is not failure of care. This is actually disease progression that's happening, right? So yes, I think we did discuss addressing the family's distress around eating, because eating is associated. I mean, as long as a person is eating, everybody is okay. And the moment they stop eating, that is the most important thing. Anybody who would like to take a quick comment on this?
I would just want, sorry, may I? Right.
Yeah, sure.
So I would just want to add about the fad regimens and the Navjot Singh Sidhu regimen, as we call it, the NSS regimen. So I had today in the OPD, I had 4 patients who came up to me and asked me about the sugar intake. Ki doctor, hum sugar ekdam band kar de kya? So I think we do that a lot in our everyday practice, and we have to counsel them about the first point: what helps, what doesn't. Try to make a balance between what the patient wants and what the relatives want, in terms of just sometimes relatives just take away all the nutrients because it's a fat diet. So we need to counsel them and try to maintain a balance between the two family members as well. So just wanted to add that.
Yes, yes.
So very rightly said. I was about to say that only, because in India, we actually, as a nutritionist, we come across a lot of myths that are being followed. And I think most commonly that we hear, definitely what you talked about, is the sugars. Now, also milk and milk products, and curd, which is supposed to be a very good probiotic. You can talk about calcium, protein, easily digestible form. Smoothies and other things can be prepared. So, these myths, specifically with the season that right now we are in, I mean, there in India, there are a lot of myths. So I think that's very important, that we need to educate not just the patient, but their families, and give them the various things that they can have, lot of options which can be easily available to them, and they can make it easily, themselves.
Very well. That's so important. Thanks for touching upon that. Yeah, early nutritional counseling, focus on pleasure-based eating, gentle resistance activity if feasible, address emotional and caregiver distress. Yeah, so yeah, I think we have reached the take-home message that cachexia is not equal to starvation. Early recognition matters. Drugs are palliative and not curative. Multimodal care is very essential, and communication is a core intervention. We all, as oncologists, palliative medicine specialists, dietitians, and so everybody needs to be, empathetically communicating with the families around this. Yeah.
And sixth point there is, it is time to have end of life care discussion.
It is. It is indeed. It is indeed. It's very important to add what lies ahead, and identifying their goals as comfort would be very important when we reach this stage and terminal stage as well. To initiate the discussions around early, what to anticipate. As one of the medical oncologists once told me, that I refer my patients to you when I'm giving the last line of chemotherapy that I know is not going to work. So I refer my patient at that time to you, so that, with the thought, okay, this is not going to work, but I'll still give, and then so that they have a rapport with you. So yeah. Thank you. Anybody who would like to take any last comments? I think otherwise I'll stop sharing my screen now, and we will have last comments by our esteemed panelists.
Dr. Megha, Saurav here. So I think audience don't wanted to leave you without asking questions. So we have number of questions in the chat box. I was thinking, so how to address that? Yeah, at least few questions we can
Sure.
address by 5 to 10 minutes.
Saurav, go ahead. Shoot the questions.
Few of the questions has been already addressed that I will skip. Otherwise, there is a quick questions is like from Dr. Robi Kiran. He's asking that especially if, tier 2 and tier 3 cities, the baseline weight is not known. So mostly patients say that they have never taken or lost weight, but not actually weight. So how can we use and validate the tools where the baseline weight is unknown?
Okay. Anybody who would like to take that? Dr. Ashutosh, Dr. Mansi?
I think, normally such cases, we don't take weight every day. But I think if you ask the family, they would say whether there has been a drastic, so they would say she was about 5 kilos more than this. So, or she would
I
say
agree
that.
on
So that a rough estimation can be got from most of the time. So it's not only in tier 2, tier 3 city, even tier 1, not everybody takes a weight. But I think you can gauge with a conversation with the family, you can make an estimate of the initial weight.
Thank you, ma'am. So the next question was a small question is like, would you like to prescribe glutamine supplement during radiation therapy?
Glutamine supplement, yes, for your radiation reactions, yes, but generally I don't use. I stress more because it is an additional cost to the patient. So my patients have done well without glucose. But of course, when there's a lot of reactions, well, I stress more on food and the nutrition. I take help from the people like Deepti and keep the family engaged, make some changes in the food, its nutritional level and the type of food. I would go more for, the normal homemade food.
Okay. So, so during so one of the question which was of I think CEO esophagus, that is already addressed by Dr. Sarupa, I think, if I'm not wrong. No, Doctor. One second.
Yeah, I have answered that.
Yeah, you have answered that. Okay. So that's all. The few of the questions already answered during your discussions I can found. So this is what audience has find that this discussion is very excellent, and now I like to over to Dr. Sanjay Kamble also. And I just wanted to share that today again we are successful, almost close to the final count. I can see that the count is being live during the meeting, the number of audience we have now. So around 140 to 145 live count, the audience, the students, the residents are watching to us, getting a lot of insights from you and enjoying the sessions. So thank you to all of you, especially Dr. Megha, who has spent your valuable time, Dr. Sarupa, Dr. Gaurav, Dr. Megha, Dr. Mansi. So each and everyone, I don't want to miss anyone. So each and everyone who has spent your valuable time today and spoke about a topic which is again and again, Dr. Sarupa has said that it is a rarely discussed topic. So it is an unmet topic that has been discussed widely. Thank you very much.
Thank you, Dr. Mega, for that wonderful navigation and all the eminent panels who could make this program a very successful one. I suppose this is program wherein the audiences are increasing as and when the time has been progressing. So that is really
Correct.
that is the success of the whole discussion that we could see. So
Yeah.
basically, usually what happens is there is a decline in the audience as the time progresses, but this is something which is the audiences are still there. So that makes the discussion very fruitful, and I am very much sure that this really has added value to the delegates who were attending the program, and that should really translate into a better patient care
Yeah.
going ahead. Thank you so much.
Dr.
Thank
Megha,
you. I would
please,
like to thank
two
Samart
lines
for
before
this.
you are closing.
Yeah. So I would like to thank Samart for, pushing us to do this. And it was an absolutely wonderful, we also gained a lot of insights while, we read a topic and we regain insights on such things. So absolutely wonderful. And thank you so much, all the panelists, for sparing your valuable evening time with us and for adding so much value to this entire conversation. Thank you.
Thank you, Dr. Megha,
Thank
for
you.
involving the multidisciplinary and multifunctional team. We have the head dietitian from your hospital, so who has also given a lot of insight today, along with the radiation oncologist and medical and surgical oncologist.
Yes.
With that, I would like to close the sessions. I thank you again to all of you. Special thanks to Mice Ideas, who has managed the platform and managed the entire technical platform for this program. Thank you very much.